All programs in the Cardiology Video Journal series are developed under the supervision of the Medical Advisory Board members, Doctors Ezra Amsterdam, Alan Miller, Leon Resnikoff, Peter Stone, and Larry Temkin.
Hello and welcome to the Cardiology Video Journal. I'm Dr. Peter Stone and I will be the moderator for Volume 16, which will address prevention and regression of atherosclerosis. We are fortunate today to have two experts in this area with us to discuss the current status of our understanding. They are Dr. Valentine Fuster, who is the Mallinckrodt Professor of Medicine at Harvard Medical School and Chief of the Cardiac Unit at Massachusetts General Hospital, and Dr. William Roberts, who is the Chief of the Pathology Branch of the National Heart, Lung, and Blood Institute and Professor of Medicine and Pathology at Georgetown University in Washington, D.C. Coronary atherosclerosis remains the leading cause of death among both men and women in America and in much of the industrialized world. In recent years, there have been important new investigations studying aggressive efforts to reduce serum cholesterol and the impact of such efforts on coronary atherosclerosis and the clinical manifestations of coronary artery disease. These efforts have focused the attention of the medical and lay community on the benefits, risks, and costs of cholesterol reduction and have stimulated both discussion and debate. Our discussants today have made major contributions to the understanding of coronary atherosclerosis and the potential for halting its progression. I would like to start with you, Dr. Fuster, and ask you to give us a brief overview of the development of atherosclerosis, how do plaques develop, and how do they progress?
Thank you, Peter. Well, first of all, atherosclerotic disease begins at a very young age, and from a clinical point of view, we like to divide the disease in 5 different stages. Stage 1 is intimal hyperplasia, which tends to begin within the first 2 or 3 years of age and is practically present on everybody under the age of 25 years. Stage 2 are very specific lesions that had a high content of fat. Originally, these were the so-called raised fatty lesions or fatty streaks. And these lesions may predispose to stage 3 of the disease, which is with their rupture or disruption, they can give the actual bed for the development of a thrombus, which in general is a mural thrombus, small thrombus, which tends to become organized by connective tissue. Stage 4, we like to call also a rupture of a plaque, but this time is with an occlusive thrombus as a complication, leading to an acute coronary syndrome, unstable angina, ischemic sudden death, or myocardial infarction. And finally, stage 5 of the disease, in our view, is a severely stenotic plaque, which suddenly occludes by a blood clot. There is no plaque rupture. And in general, these occlusions are quite silent. That is, the patient with time has developed episodic ischemia because the severely stenotic lesions, collateral circulation develops, and at the moment that this artery occludes, it's a silent phenomenon. The collateral circulation takes care.
And Dr. Roberts, how do the various risk factors of lipids, cigarette smoking, hypertension, and other risk factors influence the natural history of coronary atherosclerosis?
Well, they all obviously influence the natural history, but as far as I'm concerned, there's only one atherosclerotic risk factor, and that's a total cholesterol level greater than 150. I guess one should also put HDL level less than 35. But things like systemic hypertension, they are what I like to call indirect risk factors because in and of themselves, they are not direct. That is, if a person has a total cholesterol of 140, it doesn't matter what the blood pressure is, how high it is, it will not in and of itself produce atherosclerosis. Now, if the total cholesterol level is greater than 150, let's say the total cholesterol level is 200. If the person has a blood pressure of, let's say, 110/60 and does not smoke cigarettes, the true risk for that individual is 200. On the other hand, if the total cholesterol is 200 and the blood pressure is 180/110 and the person smokes a pack of cigarettes a day, the actual risk elevates that total cholesterol from 200 let's say, to 240 or 250. So in people who start out with a total cholesterol higher than it really should be, things like hypertension and cigarette smoking do indeed accelerate atherosclerosis.
How would you envision HDL would fit into this kind of scheme, especially, for example, someone who has a low total cholesterol?
Well, first of all, I tend to agree with Bill about the importance of dyslipoproteinemia, probably the most important risk factor. I would say that HDL, and maybe a biased view, is as important as LDL. That is, a low HDL of less than 35 milligrams DL, to me, is as important as an LDL or a serum cholesterol higher than 240 milligrams DL. It is quite interesting that when you stop smoking, the incidence of acute coronary events suddenly decreases. It's a sudden change. And I think this is because cigarette smoking probably relates as a thrombogenic risk factor, and that is many plaques may rupture, but if they rupture in a cigarette smoker, the possibilities of a big thrombus to take place are probably much greater. And if you eliminate that risk factor, many plaques may rupture, but no thrombus formation may occur. Is a concept that we have developed based in the experimental laboratory work.
The person who has symptomatic myocardial ischemia and the total cholesterol is, let's say, 190, you can count or predict that that person's HDL is going to be around 25 or something like that. It's going to be on the low side.
Dr. Fuster, what types of intervention are available to induce regression, and what is their apparent mechanism of action?
Well, the principle of regression is to make atherosclerotic plaques smaller, and the component that really can be affected is the lipid component rather than the fibrotic and the calcium component. Therefore, modification of lipids, lowering LDL when it is elevated, and if it is possible to raise HDL, is the most important approach. And this is the approach that has been taken in the 6 published studies on regression thus far available. Now, of course, I think that one should add that when we talk about regression, in fact, what is being accomplished is prevention of progression according to these 6 studies. These were arteriographic studies. Prevention of progression, and at the same time, some degree of regression of severely stenotic lesions, not very striking, but rather striking was the decrease of coronary events, maybe related to small fatty plaques, not necessarily arteriographically visible. And I think this, to me, is what regression is all about: prevention of progression and decreasing coronary events related to small plaques.
So it may be that the obstruction per se is not changed, but just perhaps by altering the extracellular lipid pool, the plaque is less prone to rupture. And that is what's conferring the stability.
This is my interpretation of the data.
We've been focusing on LDL reduction as a mechanism to reduce progression. What is your thought about raising HDL, perhaps particularly for those with low HDL-associated coronary artery disease?
Well, in most of the studies on regression, arteriographic studies, it was a reduction on LDL, but was an increase in HDL. For example, in the FATS study from Greg Brown, the results in terms of regression and the results in terms of cardiovascular events were more significant by univariate analysis as related to HDL increase than LDL decrease. But I think both are important. I would say that the reason for why we have HDL is most likely is to get rid of excess fat in areas where it's not needed. So it's like an equation. You decrease LDL, less fat gets into the vessel wall. You increase HDL, there is more of a removal. And if you have a high LDL or a low HDL, you unbalance the system. So I think you have to work at both.
I think it's good to keep in mind, however, that there are plenty of means to lower the LDL, but to raise the HDL can be a major problem. exercise is good and losing weight is good. The problem, it seems to me, is the person who has an HDL of 20 and almost nothing gets it past 30. The person who starts with 45, it might be pretty easy to get it to 60. But those who really need it the most, the drugs are not very good, and the other means aren't either.
Above and beyond the impact of lipid lowering, Dr. Fuster, you mentioned earlier in the natural history of atherosclerosis that thrombosis often punctuates the course of progression. What is your thought of the role of antithrombotic therapy to prevent progression, perhaps induce regression of atherosclerosis?
Well, first of all, I will say that we should work on primary prevention, working on the lipids and so forth. But certainly what happens is many plaques become complicated by thrombus, and then antithrombotic therapy might be meaningful if you could predict the individuals who are prone to thrombosis. And I think we have a reasonable good feeling today, and that is any individual who has more than one risk factor for coronary atherosclerotic disease, this lipoproteinemia, smoking, and so forth, is predisposed to thrombotic complications. And I would say that if we are going to use antithrombotic agents, the cheapest and certainly very valuable being aspirin, I would advocate it only in people who have significant risk factors for atherosclerotic disease that cannot be modified by normal means.
What about calcium channel blocking agents? They've been shown in some preliminary studies to reduce atherosclerosis, perhaps the early lesions. Do you think that will turn out to be a valuable intervention as well?
Calcium channel blockers prevent intimal hyperplasia in the animal models and also can modify the entrance of fat. What these studies have shown is that you can modify small plaques, induce regression, but they have not shown much on severely stenotic plaques from the arteriographic point of view.
I think it is important that the calcium antagonists are lipid neutral. That is, they do not lower HDL, they do not raise triglycerides, and they do not raise LDL, and they do not raise total cholesterol.
How safe are these various interventions? There's been the concern raised that excessive lipid lowering in some of these large trials is associated with excess number of deaths, particularly traumatic deaths, suicide, et cetera. Is this real? Is this just a quirk in almost every study, or is there something to it?
Compared to what? I think that atherosclerosis is the most toxic disease in the Western world. It's going to kill 45% of us in this country. Now, the toxicity of the lipid-lowering drugs, the antioxidant drugs, is trace compared to the toxicity of atherosclerosis. If you take one drug, for example, which has a lot of studies, lovastatin, 20 milligrams a day of lovastatin, there are no more toxic effects than occurred in placebo. So the toxicity of these drugs, I think, is the same with the bile acid resins, same with all the HMG-CoA reductase inhibitors, same with Probucol, same with nicotinic acid. I think they're relatively non-toxic drugs. In my view, they should be used much more rather than much less.
I think the interesting question, though, do you have to go to a cholesterol of 125? And the question is, we need cholesterol. And we need cholesterol for the makeup of the vessel wall, particularly the membrane of the cells. So I'm not surprised of the data, for example, that in hypertensive people with very, very low levels of cholesterol, there is an increased incidence of a stroke. There are already published about 5 studies in the last 3 years. But you are talking about very, very low levels. I'm not surprised also that if you are very, very aggressive in bringing cholesterol close to 100 milligrams DL, maybe some alteration in the mental metabolism, which may lead to some of the problems that we heard. The fact of the matter is be sure that we go along with nature. And I think in a 50-year-old, the normal cholesterol should be about 150 milligrams DL, and this is what it was at the beginning of the century. To go much lower than that, I'm not entirely sure it is necessary.
What would you consider the best methods to assess coronary regression? Is it worth, at this point, simply waiting for clinical events? Should there be duplex scanning of the carotids, of the femoral arteries, serial quantitative angiography? How should we gauge the success of what we're doing?
I would call clinical events. And I really think that this is where the impact of these regression studies, in the longer studies with the largest number of patients, actually is in coronary events. I think this is number one. Then I think in order to investigate what you are doing, you need imaging techniques. And I think it is fair to go externally in the carotid arteries with ultrasound, in the peripheral arteries. I think since we have so many patients with coronary artery disease, it is fair to look at this with angiography. Finally, I think we will learn with intravascular ultrasound significantly in the near future when we were able to see what plaques the individual has, what is the composition, and what are the plaques that are leading to trouble. But number one, to me, are coronary events, what we should be looking at in terms of regression.
And at this point in our understanding of the process of progression and efforts to induce regression, who should we apply these interventions to? What threshold should we have to identify the patient who should be treated? And what goals should we have of what their treatment outcome should be, both for people who have established coronary disease or those who may simply have the risk factors and be prone to the problem?
The recommendation is that if a patient has a cholesterol level of more than 240 milligrams DL and an HDL level of less than 35 milligrams DL, something has to be done regardless of whether there is a family history of coronary artery disease. And you should take care of these levels and try to bring them towards normal, towards 200 milligrams DL and HDL, if you can, to 40 milligrams DL. Now, if such an individual has, in addition, cigarette smoking, hypertension, other risk factors, I think you have to be more aggressive. And I think what Bill said is correct. I think you have to aim at being much more aggressive from the point of view of lipid-lowering drugs and so forth. And I think if a patient has atherosclerotic disease and has an LDL of 240, I think you have to be very aggressive because we already mentioned how important this risk factor is. I would aim at cholesterol levels below 200 milligrams DL, except on the individual who has significant risk factors for coronary artery disease or atherosclerotic disease. I would go as close as to 150 as I can.
In the USA, we have approximately 6 to 7.5 million people with symptomatic myocardial ischemia. Now, to me, all of those individuals should be treated with a low cholesterol, low-fat diet, plus a lipid-lowering or antioxidant drug or both. And I don't care what their total cholesterol level is, because whatever it is in that group, it's too high. So I would not focus on the numbers after an atherosclerotic event. I would get it lower, and I wouldn't wait 6 months to start drug therapy, because the most dangerous period after an atherosclerotic event, as you've already said, is the first 6 months. So I would start them on a dramatic program. Now, that would take a lot of discussion to convince somebody to go on the ideal diet, which is a vegetarian diet. But if you want to live longer after an atherosclerotic event, the ideal therapy is a vegetarian diet and lipid-lowering therapy. Now, in somebody who's never had an atherosclerotic event, primary prevention, I would certainly agree with Val. There, you treat the numbers. But the problem is we have 25% of the population in this country over age 20 has a total cholesterol greater than 240. Now that's 40 million people. So it's a bottomless pit. But the lower the total cholesterol level, the fewer the atherosclerotic events.
Thank you very much, Dr. Roberts and Dr. Fuster, for your valuable contributions to this discussion. Clearly, much has been learned about the process of atherosclerosis and plaque progression. Early experience has already been reported concerning the success of lipid-lowering strategies to intervene in the natural history of coronary atherosclerosis. Aggressive intervention appears to reduce the size or bulk of the atherosclerotic coronary obstruction, but there may even be an additional and perhaps greater benefit from stabilization of existing plaques to reduce their vulnerability to rupture and thereby reduce their tendency to induce an acute ischemic syndrome. However, not all atherosclerotic plaques may be amenable to acute intervention, that it may be the younger, smaller, less obstructive plaques with a soft lipid pool and a thin fibrous cap that is both most prone to rupture and most susceptible to successful treatment with a pharmacologic agent. Identification of these vulnerable plaques remains a challenge for even invasive diagnostic techniques, and we will undoubtedly see more newer techniques available as time goes on. The current guidelines for the American Heart Association and the National Heart, Lung, and Blood Institute include that lipid-lowering therapy should be primarily directed at elevated LDL, with a goal of therapy in those patients with a total cholesterol of about 200 to an LDL of less than 130 milligrams per deciliter in patients with coronary artery disease established and with few coexistent risk factors. New information may emerge concerning guidelines for treatment of low HDL atherosclerosis, as well as for triglycerides and other fractions of cholesterol. As our tools and methods to reduce serum cholesterol evolve, and as investigations in the basic sciences and clinical trials become available, we will undoubtedly see further refinements in our understanding of atherogenesis. If these efforts, in fact, demonstrate that we can halt or regress atherosclerosis and prevent clinical events, then clearly there will be dramatic effects in the industrialized world with important effects on both the health and socioeconomic status of much of the industrialized world. Thank you for joining us.
The preceding program has been sponsored by an educational grant from A.H. Robbins and Wyeth Erst Laboratories. Please join us as we present future issues of the Cardiology Video Journal.